the dentists are asking PCP for an evaluation. So you may get somebody that comes to you and says, hey, my dentist told me to come and see you. In the past, we used to give antibiotics. We're liberal in giving antibiotics. The dentists were liberal in giving antibiotics. But now, since the guidelines have become a little more stringent, the dentists are saying, wait a minute, I need a doc to really look at this patient. Risk for dental procedure causes endocarditis is 1 out of 400. But you want to take a chance, 0.25% of your patients are going to get endocarditis after a major procedure. So I asked 3 questions. What's the underlying heart condition and or some kind of prosthesis or AV shunt or knees or whatever that. The second question is, what procedure is being planned? Because remember, all this is planned. All this is prophylactic antibiotics. And then the third is, what antibiotic am I going to use? It's in those sequence steps. You take the first step. If it's positive, you go to the second step. If it's positive, you go to the third one. If the first one's negative, you just stop. This is complicated, but it's not. What you should do is one time read it. That's it, and forget it. But at least you know where it is when you need it. So basically, the top box says these are the procedures, 13 procedures that we recommend the patient to get prophylactic antibiotics. Okay, the first box. The second box says if any of the second box, no prophylaxis indicated. So keeping in mind, 10 years ago, 15 years ago, I didn't have the AV shunt for hemodialysis. I didn't have the knee surgery. I added that. Over time, it evolved. And I just added a few things, but I didn't change the concept. So the theory stays the same. The facts have changed a little bit over time. And all of these are validated by the American Heart, American Dental, American Orthopedic Surgeons. I took all of that and made sure that this table was accurate. So whenever you read or talk to a patient, you say, okay, what procedure, what underlying pathology do you have, and see if it matches up in box upper or lower. If it says not recommended, you just stop. If it's one of the top 13 on the top box, you go to the next one. So prosthetic valves, and I put them in sequence, by the way. I put them in priority. So the top 4 or 5 are high risk, the middle is moderate, and the next group is sort of in between, like a little bit lower risk. So I try to put as much as I could in a priority list based on literature that's out there. And the bottom list says, hey, if you had a previous open heart surgery, that is not a risk. Stop. Don't worry about endocarditis. If you had a orthopedic prosthesis that's more than 2 years old, not a risk. Vascular graft, more than 6 months old, not a risk. So you got to keep these things in mind, all right? So the second step would be to say, what procedure is this patient going to have? And so you put them in box A or box B. Simple. Top box is recommended, bottom box says no. So based on the procedure, if they say, I'm going to have an elective cardiac cath, it happens to be on the bottom box. Stop. No prophylaxis. Even though they may have a mitral valve with a murmur, but if they're having a cardiac catheterization, it's elective procedure, it's sterile, don't do anything. You gotta go in sequence. Does that make sense? So let's say here you're saying that the patient had a mitral valve prolapse with a regurgitation murmur on exam. So you're going to say, I'm going to prophylax. Next step, oh, the guy's going to have elective heart catheterization. Stop. Nothing. All right. Then the third step, of course, is antibiotics. So it's sort of relatively simple in my mind. No one's going to come to us and say, I'm going to have a heart catheterization next week, and do I do endocarditis prophylaxis? The cardiologist is going to take care of that, right? If someone's going to get a bronchoscopy, the pulmonologist is internist. He'll take care of it. Or GI colonoscopy, all that. But what we are going to get is a dentist. Dental procedure. They're going to come to us and say, I'm going to get this root canal done next week. What should I do? Or my dentist told me to come to you. Because again, dentist doesn't know if he's got a mitral valve prolapse with a murmur or not. He has no idea. And nor does he want to know. He just wants you to decide what he or she should do. So basically these are antibiotics, what agents, and of course the top says oral. if you're allergic to penicillin, and if you're unable to keep orals down. So the bottom box, forget it. No one's going to come to us and say, I'm vomiting, I'm going to have an oral procedure done next week. So really the top line is all you got to worry about. So just worry about amoxicillin, ampicillin. That's all you need to do. Let's look at that same patient that we reviewed, and we said, the question said mitral valve prolapse. It didn't specifically say whether you had a murmur or not. And of course, when you examine, the guy's got a murmur. So now if you have a murmur, what do? Go back to step one. Step one, it says mitral valve prolapse, regurgitation murmur. This is math now, okay? This is nothing to do with medicine, guys. You just ask 5 questions, put them in this grid, you get an answer. And you do not have to have an MD or NP or PA behind your name to do this. This has nothing to do with medicine. So it's simple as it can get. It's a mathematical formula. So you can say, okay, mitral valve prolapse with a murmur. Yes, I need to prophylax. And then the next step will be, what procedure is this patient having? And the patient told you that next week he's going to have a dental extraction. It falls into the category that says recommend. Okay, I go to the next step. He's going to take PO. What am I going to give him? Amoxicillin. How much? 2 grams. Done. 1 hour before. And again, I think over the years, because of the literature is less and less favorable to say that we're doing anything meaningful to patients by giving the prophylactic antibiotics for dental procedures. I think even the dentists are becoming more liberal of doing procedures and not really giving prophylaxis. But given if you got bleeding, root canal, some of these extraction, you should be thinking about it. If someone comes in and says, I had my artificial knee put in 6 months ago, and they're going for extraction of tooth because they're going to need it. And we need to know that. This is a 31-year-old who presents to our health center basically saying, hey, look, I am looking for prophylactic antibiotics because I have my dental extraction next Tuesday, and my dentist told me to come to you. Because apparently the patient told the dentist that he had a mitral valve prolapse, and he was told in the past to make sure that he gets antibiotics before he does any kind of dental procedures. Now, I don't know, but a dentist probably is not going to be auscultating you. And if he did or she did, probably would not be able to pick up a murmur. So this patient was asked to come to the primary care physician and get that evaluated. There's a lot of, obviously, literature over the last 10 years that's sort of all over the map. And the mortality is still high. And essentially, there's 5 different types of endocarditis. We're specifically talking about bacterial endocarditis, all right? And, literature dates back in the early 1900s and 1920s and 30s and 40s. They started looking at relationships between procedures and infection and outcomes. So this is some topic for over 100 years and getting refined and refined. But over the last 10 years, it's really taken a little bit of a shift in terms of what the American Heart Association and other associations are recommending. So I think it's worth a deeper dive. The past was 1 dose of an antibiotic before a procedure was perceived to be thought of up until today. I think most of us would I thought about this thinking, if I get a dose of antibiotic, my bacteremia load will decrease. If my bacteremia load decreases in my blood, then my likelihood of getting subacute bacterial endocarditis is low if I were to get a major dental procedure done tomorrow, right? 1 hour before. So, but the reality is, it's not the number of bacteria count in the serum. It's not the bacteremia count's going to drop. It's actually going to not change at all with the dose of antibiotic. What's going to happen is that the bacteria is going to land up in the end organ, whether it's the prosthetic knee, whether it's a prosthetic valve, wherever it's going to land up. So the vegetation, the bacteria sits there, then the antibiotic that you gave 1 hour before the procedure is going to counteract it at the end site. It's not the bacteremia. I was always under the impression that one dose bacteremia load goes down, and if your bacteremia load goes down, the likelihood of you not getting endocarditis is high. I mean, good. I mean, you're going to drop the likelihood, but that's not true. Just remember that it's not the bacteremia load. We were always taught that any murmur in a patient, essentially, they just get prophylactic antibiotics before almost any dental procedure. That was the trend over the last years, and that's shifted. In the past, we used to have a lot of patients that required prophylactic antibiotics, but I think over the recent years, those numbers have dropped because our threshold has dropped, our surveillance has dropped, our just kind of it's just gone off our radar. But yet, there's still certain pathology that we need to look at and certain procedures we need to look at that actually warrants prophylactic antibiotics. And yet, despite all of the things we just said, it's still recommended by the American Heart, the American Orthopedic Surgeons, the American Dental Surgeon Association, that there's some questionable benefit, but there's still a benefit for the high-risk patient. So we need to kind of look at the high-risk patient. So a couple of myths. What have we changed recently in our process or protocols or the literature that's out there is that the amoxicillin in the past used to be 3 grams, now it's 2 grams. The second dose is no longer needed. Some of these little trivial things have changed over the last 10 years or so. And erythromycin is just as good as clindamycin and some of the other drugs. A lot of times I get patients in the ER and, you know, they come with dental abscess. I'm so aggressive. I said, let's put them on clindamycin. But really, the dentist will tell you amoxicillin is just as good. I think we just do an overkill sometimes. And they're saying, like, your second drug of choice should be just erythromycin, something simple, if they're allergic to penicillin, and not jump to something really aggressive. Now, the dentists are asking PCP for an evaluation, and then they come to see the dentist before they do some kind of a procedure. So you may get somebody that comes to you and says, hey, my dentist told me to come and see you. So don't freak out and say, go back to the dentist, he'll decide whatever he wants to do. Because remember, in the past, we used to give antibiotics, and we're liberal in giving antibiotics. The dentists were liberal in giving antibiotics. But now, since the guidelines have become a little more stringent and a bit more refined, and you have to have a murmur, you don't have to. So now the dentists are saying, wait a minute, I need a doc to really look at this patient. The cumulative exposure is 100 times more in terms of the bacteremia sometimes, rather than just a simple procedure, dental procedure, so or a scope, or tonsillectomy. So you got to keep that in mind. That sometimes we need to take it with a grain of salt. That this procedure, is it going to really cause a problem? Are we going to do good with the antibiotics, or are we just abusing the antibiotic? So the risk for dental procedure causes endocarditis is 1 out of 400. So, do you want to take a chance? 0.25% of your patients are going to get endocarditis after a major procedure. So probably not. If we can avoid that, why not, right? So let's kind of look at some of the specific guidelines. Before we do that, this is something that we just spoke about, that a dental extraction will cause around 25 to 85% bacteremia. Just a periodontal surgery, chewing gum, just brushing your teeth will cause bacteremia. So basically, keeping in mind, a lot of simple things cause it, okay? Because obviously your oral cavity has a lot of blood supply, so even the micro trauma will cause an infusion of bacteria into your bloodstream. So a couple of the societies out there, majority of them, American Heart Association, the American Academy of Orthopedic Surgeons, really came up with some of these statements recently in the last few years, and saying they're against routine antibiotic prophylaxis in patients with prosthetic joints. And this is from the orthopedic surgeons. And in the past, what used to happen 10 years ago, someone comes in and says, I got this prosthetic knee. Now the question is, do they get antibiotic prophylaxis? Do we treat them like a prosthetic heart valve? And the answer is yes, it is. But we have to look at the duration. We have to look at when was this prosthetic knee put in. Was it 2 weeks, or was it 2 months, or was it 2 years, or more than 2 years? And based on that, we can categorize them into low, moderate, or high risk, and then decide on the prophylactic antibiotics. Okay. So I'm going to make you dizzy for the next 30 seconds. So it's best you can close your eyes. There's a lot of literature out there, right? A lot of graphs and tables. The data is just inundated. So, this is basically saying, hey, if you have these following cardiac conditions, then we can bucket them into 3 different buckets. On the right says don't do anything, bucket. Middle says moderate risk, and the left says high risk. So these are different buckets, cardiac underlying problems. But remember, we were always taught about the cardiac, but then we forgot about the recent stuff that people are doing. What about a patient with hemodialysis that's got an AV shunt, right? That's kind of a prosthetic. It's a plastic. It's foreign body. Orthopedic surgeons were left out 20 years ago because all these new procedures and more people are getting more and more knees and hips and shoulders and whatnot. So more and more people are getting renal dialysis with AV shunt. So we need to consider some of these other folks in this metric and not heart. So again, data's there. There's a lot of it. So this one talks about what conditions are we looking on the left-hand side. Middle says yes or no, and the right says who's validating that data. All right, so there's good validity on the data. And then this one particular says what procedures are at high risk in specific. So now this one includes even colonoscopy or a vaginal hysterectomy, or if you had a C-section, it carries no risk because it's a controlled environment, sterile operation. But if you have a tonsillectomy, you can't do a sterile procedure in anything in the oral cavity. It's all bacteria. So basically, that would require, and that would be a high risk. It's interesting. One day, I was scrubbing in for as a resident for an oral facial mandible. To clamp the mandible down. So I was like literally scrubbing like in the surgery and for 20 minutes and whatnot. And suddenly the resident like literally got pissed off and said, dude, come on in right now, start working instead of like wasting your time beautifying your hands. Then I realized that your oral cavity OR is just an OR for sedation. It's not a sterile technique at all. Obviously, I didn't think about it. So you don't need to wash your hands to do a procedure in the mouth. It specifically talks about route. Are you going to give PO, IV, IM? And basically, if you do PO, then they say 1 hour before. If you do IV or IM, you can do 30 minutes before. So, there's some variance. So again, a lot of data, a lot of graphs, a lot of tables, and it's difficult to follow all of this. This is more on saying what antibiotic options do you have. So really, I think the key thing is how you're going to organize this in your head. And this specifically talks about above the diaphragm and below the diaphragm. So if you have a procedure that's above the diaphragm, the bugs are different. Below the diaphragm, the bugs are different. So you're going to have different antibiotic choices based on the organism that you're going to most likely contaminate the patient with. So this is basically saying below and above the diaphragm, what bugs, based on the bug, what bug juice and what dose and what route and how many minutes before. So it kind of summarizes this.